Clinical evidence. The clinical evidence of the presence or the absence of gonococci, which has been for so many centuries the physician's only criterion, is overshadowed nowadays by recent advances in bacteriology. Yet, the bacteriologist is by no means infallible, and it is absolutely essential that the clinical evidence should accord before the laboratory is permitted to conclude that a patient is clean. The notable clinical evidence of the presence of gonococci is pus, and in view of the prevalence of gonorrhea, it is a general rule that whenever there is pus anywhere in the genital or the urinary tract, the presence of gonococci may be suspected. And conversely, when the whole tract is proved free from pus, the presence of gonococci may be denied. Footnote: with the single exception that the patient may have just been infected and may still be in the incubation period. Clinically speaking, a great many classes of cases may be ruled out at once. Thus, gonorrhea of the kidney is very rare and never occurs except in conjunction with gonorrhea of the lower urinary passages. Similarly, the history of suppuration due to prostatism, stone, tubercle, or tumor is usually such as to rule out gonorrhea. The cases that come for diagnosis may be divided into three classes. First, those who, having had gonorrhea, continue to have pus in the urine or are subject to relapses of pyuria or urethral discharge. Second, those who, having had gonorrhea, whether they allege a continuance of the discharge or not, are not subject to acute relapses, no matter how much sexual and alcoholic dissipation they indulge in. Third, those who, after a gonorrhea, have no longer a discharge or any other symptom, show perfectly sparkling urine, and from whose prostates and vesicles no pus can be expressed. Of the first class, the majority are still infectious. Of the second class, the majority are no longer infectious, while all who continue in the third class for a month are certainly free from gonococci and from all danger. For these last, then, the clinical diagnosis suffices. For the others, there is only a probability from which the experienced physician may often reach an assured conclusion one way or another, but a probability which always deserves to be confirmed by scientific test. The following points are also of assistance in the clinical diagnosis. The presence of shreds in the urine, even when those shreds contain pus cells, is not probable evidence of the presence of gonococci unless free pus appears in the urine from time to time. Indeed, pus shreds appear constantly in the urine of many men who never had gonorrhea. When the discharge and the centrifuged urinary sediment show a preponderance of epithelial over pus cells, gonococci are very probably absent. When the gonorrhea has lasted 3 years without reinfection, gonococci have doubtless disappeared. Finally, the clinical evidence is much fortified by excitation of the urethra. To this end, the patient may be put through the following 3 tests at intervals of 48 hours. Vigorous prostatic and vesicular massage, 3 glasses of beer, dilatation with a Coleman dilator. If these 3 tests fail to excite a discharge from which gonococci may be cultivated, the gonococci have almost certainly disappeared, even if the urine or expressed prostatic secretion continues to show pus. Footnote: injection of gonococcus vaccine may excite hidden gonococci, but this test is not infallible. Laboratory evidence. The consulting urologist is besieged by patients who, at the close of a gonorrhea, with urethrae more or less completely healed, are gonococcus free as far as the complement deviation test, culture, and clinical signs can prove, and who yet are driven to an agony of doubt because they continue to show a few intracellular gram-negative cocci, degeneration forms of staphylococci, and pus cells. The mere presence of gram-negative intracellular diplococci in a chronic urethritis does not warrant the diagnosis of gonorrhea, unless these are numerous and typical, page 111. Therefore, the examination of smears decolorized by the Graham method is a peculiarly misleading test of the cure of gonorrhea, unless the examination is made by a peculiarly expert bacteriologist. The only laboratory test worthy of credence are the complement deviation test and culture. The practitioner who cannot command one or both of these must perfect himself in the clinical diagnosis and rely upon this. The complement deviation test is not reliable until the patient has had posterior urethritis at least 2 weeks. But the more chronic and the milder the urethritis, the more reliable is this test in comparison to culture, which is most accurate in active recent cases. Practical method. When the gonococci seem clinically to have disappeared, when the application of the beer, massage, and dilatation test no longer at sites of discharge loaded with gram-negative intracellular diplococci, we apply the following test. 1. Wait 2 weeks. 2. Then apply the complement deviation test. And 3. Examine by smear and culture. A. The urethral discharge. B. The first urine passed, centrifuged. C. The urine passed after massage of the prostate and vesicles, centrifuged, or the expressed secretion from these glands. The specimens must be taken directly from the patient at the laboratory and examined before they grow cold.